Good afternoon or good evening, wherever you are. It's a great pleasure for me to moderate this ERN initiative together with Saiko Ono, all the way from Japan, midnight.
Yes.
So
Thank you very much.
So we have put together a program for you to learn about this disease entity that is termed Andersen Tawil Syndrome, which is a disease that had many phases, and we are happy to be joined by international faculty from Italy, Japan, and Denmark. And we would like to have questions between each talk, 1 or 2 questions, and in the end. And so Saiko Ono, would you introduce our first speaker?
Okay, so I'm very happy to join our study, our data to the International ATS registry. And most of the data are summarized by Dr. Kato Koichi. So, Dr. Kato, can you start your presentation from now?
Sorry, excuse me. The first speaker would be Dr. Matsanti, I think.
Yes. So I think we switched over to Andrea Massanti from Pavia, well known to the field, will start his presentation. Could you share your screen, Andrea?
Sure. Now, let me find the slides.
In the meanwhile, we could say Andersen Tawil is interesting, and it has 3 aspects. So we know that it has dysmorphic physical characteristics. You can also have neurologic symptoms, periodic paralysis, and of course, ventricular arrhythmia. Please, Andrea.
Yeah, can you see the screen? Okay, so first of all, good afternoon, and thank you very much for this invitation. I'm very pleased to be with you, and I've seen many listeners. So we will discuss briefly some introductory slides on Andersen Tawil Syndrome. That, as you know, and Jakob was remembering us, is a complex multi-organ syndrome characterized by dysmorphic features in the skeletal and in the face of the patients, and periodic paralysis. And especially for our field is interesting that the patients have very often ventricular arrhythmias, and as you can see in this example, especially frequent premature ventricular contractions. And it's indeed a very rare disease. There are approximately 2 or 3 cases per million of inhabitants. So it's something that we really need to join forces in order to be understanding something of this disease, as we have seen in the past. Here you see an example of a patient with Andersen Tawil syndrome, and what is really striking is the very high burden of PVC these patients present. Interestingly enough, these patients have bidirectional arrhythmias, and a difference at variance with the CPVT. The arrhythmias are at rest and not necessarily linked to exercise. So this is something that we need to keep in consideration when assessing a patient with frequent PVC, because this might have a therapeutic implication as well, as we will see in a moment. Another important aspect that I would like to just highlight for the youngest colleagues, the appearance of a bidirectional VT is not in all 12 leads ECG, and you really need to have all the leads to see the fact that this arrhythmia is bidirectional. Otherwise, you can miss easily this aspect. So from the etiological standpoint, approximately half of the patients with a clinical diagnosis of Andersen Tawil syndrome will have a mutation in the gene coding for the KIR 2.1 inward rectifier potassium current. As you know, this gene is named KCNJ2, and as was demonstrated more than 20 years ago by the work of Martin Tristani and Firuzzi, these mutations are loss of function mutation, and they have a dominant negative effect because the channel KIR2.1 is a homotetramer made by 4 subunits which are identical. And when we have one or more mutant subunits, then they interfere with the function of the channel overall. So from the genetic standpoint, these mutations have a so-called dominant negative effect, or also known as a poisoning peptide effect. And here you see several examples on expression systems that demonstrated that different mutations induce different suppression of the IK1 potassium current. So let's go back for a moment to the physiology handbook, and let's see how this inward rectifier potassium current work, which is also known as AK1, as you know. So the current is named inward rectifier because you see that the voltage and current relationship is highly asymmetric. And as you can see, for negative membrane potentials, so when the cell is repolarized, the channel allows inward current, inward potassium current, and you see also here represented in the phase 4 of the action potential, which helps to stabilize the resting membrane potential. Also, it is interesting to notice that the potassium channel is also activated very briefly during depolarization phase, and this contributes to the ending of the cardiac action potential. So you see that the current has a double effect. On one side, it helps maintaining the membrane resting potential. On the other side, it helps repolarization. And this is important to remember because these two behaviors are those that are affected in Andersen Tawil syndrome. In fact, here you see this work in an animal cell of Andersen Tawil syndrome that was published in 2022. And you see that when you have a mutation as compared to the wild type current, you have a dramatic reduction of this inward rectifier current. So it means that the cell loses its resting membrane potential. And this explains how it happens that these patients have a frequent PVC, because these are then, if you lose the membrane resting potential, it is easier to have a spontaneous extrasystolic beat. But the function of the IK1 current is more complex than this. Besides having this electrophysiological effect, in fact, it interacts also with the sodium channel, and it has been demonstrated that when you have these mutations causing Andersen Tawil syndrome, then you have also in the same cell approximately a 35% reduction on the peak sodium channel. And this explains again how and why these mutations have a complex electrophysiological behavior. And this is something that you will need to keep into consideration when we will speak about treatment of Andersen Tawil syndrome. So as you know, and as Jacob was remembering us, these mutations are extremely rare. Patients are rare. So actually, when we wanted to study the natural history and try to depict the behavior of this disease, we had to join forces across several centers. And in this way, we were able to get information on approximately 60 families with 35 different mutations. And here you see the distribution of the mutations in the primary structure of the gene. And we found interesting genotype to phenotype correlations. For instance, we demonstrated that the mutations that are in the C terminus of the protein are associated with very important phenotypic features in the face and the muscular phenotype, which is something that is interesting to know, because it demonstrates that different mutations have different behavior, not only at the electrophysiological level, but also in the other districts interested by the syndrome. When we come to the natural history, we see that even if we consider the natural history with or without a treatment ongoing, these patients have a severe outcome overall over time, at least in our experience. And approximately, we demonstrated a rate of life-threatening arrhythmic events in the order of 1.5% per year. And it's interesting to know that these patients might have arrhythmias also in the very young ages. This is something that we need to remember, because it is possible when estimating the prevalence of the disease that we miss some patients because probably they might die before they arrive to our diagnosis. So in our experience, we found several indicators of an increased risk, and these are, for instance, a previous history of syncope, the presence of sustained ventricular arrhythmias. So it is important to remember many patients have arrhythmias, but when they have a long stretch of ventricular tachycardia, which sometimes are not so fast, but in any case, they might be associated during the follow-up with the incidence of ventricular fibrillation. And importantly, we also found that many patients were probably treated because of the frequent PVC with amiodarone, and they, as you see, they have like a very high risk of experiencing a cardiac arrest, because in a way, these are patients with long QT syndrome, even if it is not necessary to have always the QT prolongation, but we need to remember this and not give amiodarone to our patients. The guidelines have recognized the value of this information, so that they recommend ICD implant for patients with a previous cardiac arrest or sustained ventricular tachycardia, and it may also be considered the ICD when the patients have a history of unexplained syncope, something that we need to ask to our patients. When coming to the treatment, we demonstrated, unfortunately, that no treatment change very much the natural history of the disease, not beta blockers combined with the antiarrhythmic of class 1. I know that there are newer data. This is something that we really need to explore with further details. And it's important, again, do not use amiodarone, because then you multiply by a factor of 20 the risk of having a cardiac arrest in these patients. So let's finish like coming to the new kid on the block. It's something that we already knew from many years, but I mean, flecainide is used in many patients with Andersen Tawil Syndrome, and the rationale for using flecainide is represented in this slide. First, let's see on the right side of the screen, flecainide increases the open probability of the IK1 channel, KIR 2.1 channel. So means that when we give flecainide to our channels, they open more frequently. And this is something that, of course, since we have a loss of function mutation, it's important to open more frequently the channel. And when we come to the electrophysiological behavior, look in the white circles, the flecainide, beside having an effect on the sodium channel, but it's important to remember that interacts directly with the KIR 2.1 channel, as demonstrated in this slide. It increases the current in both directions, both in the inward current, which is important for resting membrane potential, and also in the outward current, which is important also for like the repolarization phase. Interestingly enough, the authors, Caballero and colleagues, demonstrated that the effect of flecainide is specific for this variant of the channel, because, you know, there are several channels, KIR 2 point something, but the only important in the heart, or the most important in the heart, is the KIR 2.1, and especially important in the ventricles, even more than in the atria. And the fact is that the flecainide has an effect only in this channel. This is important to remember, because it's a highly specific as a treatment. And we can go even further in understanding the pathophysiology. So flecainide and propafenone, they bind to a specific residue on the KIR 2.1 channel, which is this cysteine 311. And here you see, this is the place where it interacts. And basically, by interacting with the channel, they reduce the interaction of the channel with some, let's say, polyamines that are inside the cell. And these polyamines, they are responsible for the inward rectification of the current. So in a way, when you provide the flecainide to a cell, then the flecainide interferes with the KIR 2.1 having an interaction, a relationship with these polyamines. And as a result, you increase the IK1 current in the two components. So this is why the flecainide has an effect potentially in patients with Andersen Tawil syndrome. It is highly specific. It's important to remember. And in fact, there have been some recent data by the group of Mann and colleagues that treated 31 patients with Andersen Tawil syndrome for approximately 4 years. And the effect was demonstration that they reduced the PVC burden in patients with Andersen Tawil. Of course, there are no demonstration on like, even though the the follow-up was long enough. I mean, the symptoms improved, but of course the overall effect on survival is something that we really need to discuss, especially because not all patients had the same response. Some patients had, for instance, an worsening of the arrhythmic phenotype when provided with flecainide. So this means that flecainide is probably effective. We have seen the mechanism. The potential problem is that it might not be effective for all patients. In fact, if we go back to this animal model, but by Macias and colleagues, this animal model has a delta 314-315 mutation. The administration of flecainide in the mouse had the effect of increasing reentrant arrhythmias and also induced action potential alternance, which, as you know, is a powerful indicator of arrhythmic risk. So this again means that the effect of flecainide cannot be extrapolated to all patients with Andersen Tawil syndrome. And this is my last slide. Of course, this is something that we are really interested in studying, and this work by Moreno Manuel and colleagues demonstrated, provided an hypothesis that, as you might know, there are different behavior of one mutation in respects to others. Some mutations, for instance, interferes with the trafficking of the channel to the membrane, whereas other mutations do not interfere with the trafficking of the protein to the channel. So we might speculate that the mutations which interfere with the trafficking are those which will not respond to flecainide. Whereas if you have a mutant channel that arrives to the flecainide, so this effect of inward rectification is present, then the channel might be, let's say, improved. The function of the channel might be improved when administering flecainide. And this is possibly like one of the explanation for the different response to flecainide. And with this slide, I thank you very much for your attention.
Thank you, Andrea, and thank you to all the listeners. And if you have a question, please write it in the chat. Andrea, I have one question for you. First, this may be a comment. So given the fact that flecainide also work on SCN5A or the NAV1.5, and you showed that these mutations may also influence the sodium current. What do you think the mechanism could be? Or is there a dual mechanism there?
On the effect of flecainide, you mean?
Yes.
Yeah, sorry, maybe I was not clear enough. As far as I studied, I mean, the flecainide has the two effects. One on the sodium channel, which is very known and obvious, but also it has a direct effect on the KIR 2.1 channel by having these. So basically, the fact is that this like asymmetric behavior of the voltage current relationship is explained by the fact that when this is a potassium channel that works differently from the other potassium channels. So basically, the other opens when the cell is depolarized, and they contribute to help to repolarize. In this case, when the cell is depolarized, the interior part of the KIR 2.1 channel is blocked by these polyamines that are like physically blocking the pore so that the potassium cannot go out. So flecainide binds to the channel on the inside and interferes with the interaction with polyamines. So as a result, the flecainide enhances the function of the channel. So in a way, then it helps in repolarization, and as far as I'm concerned, it has also an effect in improving the membrane resting potential. But so it's as you say, it's a dual effect. Yes.
Wonderful. There is one question for you in the chat. I have so this is
the other genes that have been, yes. Yeah, there have been like other genes, but the point is that the other genes are very minor and do not have like much relevance from the genetic standpoint. I have an impression that probably I think that the true Andersen Tawil syndrome is one related to KCNJ2 mutations, and then there may be like other conditions which simulate a bit this because we demonstrated in our data that many patients, I mean the majority of patients with these mutations, they have the phenotypic trait, they have like the muscular weakness, and they have like the arrhythmias. So I think that it is a double direction reasoning. So on one side, we need to be sure that the clinical picture is the one of Andersen Tawil syndrome. On the other side, we might not say that all mutations in KCNJ2 that we find like incidentally, they are associated with Andersen Tawil syndrome. So, I mean, this is something that we really need to consider on both sides, because otherwise we risk to create noise, no?
Very good, and I agree on this answer. So now it's my pleasure to introduce our Japanese colleague, Koichi Kato from Japan, who will present Japanese perspective on Andersen Tawil. Please.
Good evening, sir, and good evening, doctors. Can you hear my voice clearly first?
Yes, no
So I'm going to share my slides first. Is it okay now? Okay, so good evening. So thanks for inviting me for this important meeting. My name is Koichi Kato, working in Shiga University of Medical Science. So today I'm going to introduce our Japanese KCNJ2 variant carriers database. So this is the first slide is the inclusion criteria because the basic knowledge is already presented by Dr. Matsundi. So I'm going to show our database. So in this study, we gathered the follow-up information of KCNJ2 variant carriers in Japan since 2021. And our inclusion criteria is shown in the left side. So they must fulfill A and B. So A means this is ESC diagnostic criteria for ADS, and B is the patient must carry a KCNJ2 pathogenic or likely pathogenic variant. And first, we picked up 112 patients with rare variants in KCNJ2. But among these, 36 patients carried benign or VUS, so I excluded these patients. And also, pathogenic variants in other arrhythmic genes, such like KCNQ1, H2, these patients are also excluded. And one patient obviously carried gain of function variant, so I excluded that patient. And unfortunately, one patient did not fulfill the ESC diagnostic criteria, and 10 patients did not have enough information for follow-up. So finally, we got only 61 patients. Excuse me. Yes. And this is the list of our detected variants. So in the first slide, I mentioned that I excluded one gain of function variant, but I did not mean that all other variants are loss of function. Indeed, there are 5 variants. These variants were not yet functionally analyzed, but other variants were all demonstrated to be loss of function. And this is a histogram of the diagnostic criteria. So the vertical axis means the number of criteria, ESC diagnostic criteria. And the X horizontal axis means the number of patients. So for example, in the left side, 12 patients fulfilled 5 diagnostic criteria. On the other hand, 16 patients only fulfilled 2 diagnostic criteria. And for example, this dark navy color means the loss of function KCNJ2 variants, because we identified 5 variants functionally not demonstrated and not tested. So these patients did not have this navy color, but still have 2 other criteria. So they were still diagnosed as having ATS. And next slide is, yes. So this is a comparison of the distribution of our variants and those variants reported by Dr. Matsanti. And the left side is Japanese variants and the right side is the European data. And we did not find strong difference for the distribution of the variants. and I think it's quite similar. And the next slide shows the survival curve. So we draw this survival curve from their birth. The red line indicates proband, and the black line indicates family member. So you see the family member did not have any lethal arrhythmic event. But we have to mention that because we found 4,000 cases in 4 families. And so we cannot count these dead family members. So there's a strong survivorship bias in the family members. And on the other hand, in the proband, the cumulative survival rate was 72% at age 40. And we tried to find some kind of risk factor and analyzed the presence or non-presence of these traditional risk factors for lethal arrhythmic event. But unfortunately, the number of lethal arrhythmic event was too rare, so we could not find any significant difference for this kind of condition. And probably this figure will attract many people's interest. So this figure shows the x-axis is the age of each patient, and each of these orange and green bars indicate the follow-up period of each patient. And the line graph, this sky blue, navy, and dot line means the number of patients at each age. So the sky blue indicates proband. So obviously we have a peak of probands at age 15. It is because many patients were detected their ECG abnormality through the school-based routine ECG screening in Japan. So in Japan, all school students take ECG at their around this age. This is nationwide screening, and at the timing, at this chance, the patients were also tested in some cases. So the family members have their peak at age around 26, 27, around that. And what is quite interesting for me was in the sky blue line, there's a small hump in the age around 40 or 45. So many patients will first come to the hospital at age around 15, but there are some patients who present at hospital with drastic events or ECG abnormalities or some kind of syncope at age around 40 and 45. And indeed, this red dot indicates the lethal arrhythmic events. So 2 of our patients were such kind of people. They presented at hospital with ventricular fibrillation or atrial plants. So they were not treated, they were not under observation, but they presented with lethal arrhythmic events first. And all patients were observed over 13.7 years after their first visit. And if we analyze only this observational period, we only have 2 events under observation. So overall event rate was 0.25% per year, because 2 events in 61 patients over 815% years. So I think the number is quite small compared to the European data Dr. Matsanti presented before. But we did not count these 2 events because this is not the event under observation. So these events which led the patient to the hospital, the initial first visit was not counted for this kind of analysis. And this is the analysis for the medication. So first we have to mention that we did not use amiodarone to any patients. The amiodarone was not prescribed to any patients, and the majority was beta blocker, and the second majority was frequinide. The right panel shows the change of treatment. So at the initial treatment, the beta blocker was most preferred medication, but at the end of follow-up, the majority became frequinide. So it was quite popular in Japan. And this is the summary of discussion. So the overall event rate under observation in the Japanese cohort was lower than in the European cohort. And of course, the reason is the primary reason is the absence of amiodarone in the Japanese cohort. And there's a possibility that earlier diagnosis due to school-based ECG screening may have enabled the timely intervention to some patient. But what kind of intervention was had such kind of effect? It was not demonstrated because we do not have enough data. And also for the age distribution analysis, we found that ATS patients are at risk for arrhythmic events in their 30 to 40s. So at least we can advise that for young patients, continuous observation should be until ideally into at least their 50s probably, because they are not experiencing their most dangerous period at the yet. And also for newly diagnosed patients around the age 30, probably we need to pay maximum attention because they are in a higher risk. So thanks for listening. This is all of my presentation for today.
Thank you. Very clear, very interesting data. I have a question for you, and which is, so do you think that when you do screening in the schools where you pick up a lot of patients, do you do long QT screening at what cutoff? When do you initiate this genetic screening in asymptomatic school children, as it seemed to be?
I see, I understand. So yes, first these patients, most of the patients were referred to our institute for as a long QT syndrome or very or some patients were referred for frequent PVCs. And indeed, many patients first referred with QT prolongation, but in reality, they do not have a QT prolongation, but they have a QU prolongation, I think. But anyway, now the concept of ATS is well known in among Japanese pediatricians. So school-based ECG screening work very well, and many practitioners send the DNA samples to our institute for analysis.
Thank you. Very clear. Heiko, would you introduce Bo Winkel?
Yes, the last presenter is Dr. Bo Gregos. Okay. So please start your presentation.
Thank you very much. I hope you can see my presentation now.
Yes, please
Okay,
start.
so thank you very much. I was asked to present a case here today that could illustrate Andersen Tawil Syndrome, but also some of the challenges that can be in diagnosing the syndrome, and when maybe also to be aware of thinking about Andersen Tawil. And this is a case that we presented first at ERA this year, and it was presented originally by Dr. Starman. So this is the patient case. He was actually quite old, 60 years old, only known with hypertension, but no other previous cardiac or medical history. He was admitted to a local hospital, so not our hospital, but a local hospital, because he had a first-time syncope. He was out walking with his family, and all of a sudden he just collapsed. And after a couple of minutes, he regained consciousness. He was admitted to, as I said, the local hospital, where he was examined with a brain CAT scan, which was normal, blood analysis, which was normal, and then this ECG, which showed polymorphic PVCs and otherwise sinus rhythm. And besides the polymorphic PVCs, you can also see that the QT interval is not severely prolonged. He was then prescribed with metoprolol beta blocker, 50 milligrams daily, and this is what we use a lot in Denmark. And he was then referred to the outpatient clinic for further evaluation. He had a 24-hour Holter monitoring, which showed 20% PVC count, more than 12,000 PVCs during that monitoring period. He was also performing a treadmill test where you could see that the ventricular extrasystole increased during exercise, but then were abolished at peak exercise for then regaining in the recovery phase. They performed also an MRI, which showed a left ventricular ejection fraction of 50%, but with no late gadolinium enhancement. And to rule out other diseases, a PET scan was performed with no signs of sarcoidosis. So from this outpatient clinic, he was then referred to having a loop recorder implanted because there was still no explanation why he had his syncope originally. However, while waiting for this loop recorder to be implanted, he suffered from an out-of-hospital cardiac arrest while bicycling. It was a witness cardiac arrest. He was immediately having bystander resuscitation performed, and he had 4 shocks delivered on the VT-VF, and he had return of spontaneous circulation after 17 minutes, and he was then referred to our hospital, actually, and that is the first time that we knew of this patient. And so when we took him into our ward, he was conscious, and he was actually quite well despite of his 17 minutes of cardiac arrest. And so we started the evaluation of the cardiac arrest survivor as depicted in the 2022 ERC guidelines for the management of patients with ventricular arrhythmias and the prevention of sudden cardiac death. Just having a sneak peek on this flowchart for the management or the evaluation of sudden cardiac arrest survivors, I will just go through some of the steps, and what you can see was the initial ECG with no PVCs, but what you can see now is that there were quite prominent U waves at this point. The echocardiography showed left ventricular ejection fraction of 30%, but that was believed to be partly due to the stunning of the heart after the cardiac arrest, as the patient were known with an MRI with an LVEF of 50% only weeks before. The initial blood work was unremarkable, and there was a breast and chest CT scan performed with no signs of extracardiac disease. We then repeated the ECGs, and now you could see that, again, the prominent U waves, and also there were definitely frequent PVCs, which was also present on the telemetry on the wards. Going further down the algorithm for the cardiac arrest survivor, he had a coronary angiography performed, which showed no signs of atherosclerosis. There was only diffuse atheromatosis, not explaining the cardiac arrest. The MRI, as I previously shown, was already performed, and we didn't do another one only 14 days after the cardiac arrest. But we did do the elevate electrode ECGs to demask any Brugada syndrome pattern, which there weren't, and the standing ECG had no prolongation or no further prolongation of the QT interval. We went on to perform an ismaline test for, again, demasking Brugada syndrome, which was negative, and we did another bicycle test or exercise stress test, which again showed increased PVCs during exertion, yet ceased at maximum stress. But very importantly, we didn't see any bidirectional VT. So with no suspicion of vasospasm, we actually came to the conclusion for this patient that we didn't really know exactly what was the cause of the cardiac arrest, even though we could see that he had frequent PVCs and an LV ejection fraction of about 50% and the prominent U waves. So with a diagnosis that were pretty uncommon, even though we might have an idea we should look further into, maybe did a genetic testing. But with the results pending for the genetic testing, we implanted an ICD in the patient. We increased the metoprolol and we discharged the patient after 11 days. So for the follow-up a couple of months later, having the results from the genetic test, we could see that he had indeed this KCNJ2 mutation that would speak into the Andersen Tawil Syndrome. And we have already discussed this inward rectifying potassium channel that is in play in this syndrome. So having already discussed the Andersen Tawil Syndrome, I'll just briefly go through the different features that are associated with the syndrome. We have the muscular features with muscle weakness and fatigue, and we have the dysmorphic features, for instance, the low set of ears, and syndactyly, and then of course the cardiac features with the prominent U waves and the frequent PVCs, and of course ventricular tachycardia. However, this patient, he did not have either the muscular or the dysmorphic features. He had indeed the cardiac features, though. You could discuss if we had a little bit of a low set of ears, but that was not something that we diagnosed at that point. So we then moved on with this, thinking that he would probably have Andersen Tawil Syndrome, at least for the cardiac features. We looked at the family, and we could see that, first of all, we had a lot in the family that had the KCNJ2 mutation, and we had a very, very high phenotype-genotype correlation when we looked at PVC. So all patients with the mutation also had very many PVCs. And we also then looked into more closely the relatives, and we could actually see that several of them, besides having PVCs, also had webbing of the toes, thereby confirming the diagnosis of Andersen Tawil Syndrome in their family. So we, based on the mutation actually, and the likelihood of having Andersen Tawil Syndrome, we changed the medication from metoprolol to propranolol, and on that, so without flecainide, we saw a very profound decrease in the PVC counts to less than 1% actually. So we were very happy with that, and the patient has not had any ICD discharges at follow-up. So this case, I think, accentuates the significance of systematic investigation of these patients and the importance of genetic testing in cardiac arrest survivors. And the early detection and risk stratification can probably improve outcomes. At least we have now a lot of family members where we need to look closely into how to reduce the PVC burden in these patients. And there seems to be a high correlation between genotype and phenotype in Andersen Tawil Syndrome, yet there is a high variance in the clinical presentation, which is also something that has been alluded on already. So with that, I want to thank you for your attention and be happy to discuss the case.
Thank you very much for very interesting presentations. So I have one question. So the patients showed no symptoms until 60 years old, for example, palpitation or fatigue or other ATS specific symptoms.
So up to the time of the cardiac arrest, it's true that he had no symptoms or any cardiopulmonary symptoms. That's true. Although I would say that he was seen and known with these many PVCs, but it's something that apparently he has not paid any attention to, or at least seek medical attention for.
Okay, thank you.
Yeah, and and that is something that is so it's quite rare to see the presentation of the family with a proband that old. It's true, but that's also something that I think is very important learning point from this case.
Okay. So you checked the
Yes, sorry.
genetic testing for the relatives. And did you
So
check the genetic testing for the relatives? You showed.
Yes, so we did genetic testing in all the relatives, and we could see that there was a perfect correlation between the genotype and PVCs. So all the patients with a positive, with the KCNJ2 mutation, they also have a high PVC burden on Holter monitoring. So it's a perfect match. And then two of the family relatives also have syndactyly or webbing of the toes. Yeah. But I have one question maybe for you guys, Psycho or Andrea, and that would be what would be the monitoring of the effect of the treatment of the patient? Because we in this case, and this is I mean, we don't have a lot of families. We have maybe 3 families now with the Andersen Tawil. But how do you affect the monitoring of the treatment of the patient? So I'm very satisfied with a low PVC count. I think we have done a good job in treating this patient. But is that the best way to look for the good treatment in the patients, or what?
Yeah, that's a very difficult question. But for Japanese ATS patients, we feel that the prekinase is very effective to prevent the PVCs. But we have no data for long time follow-up until, for example, until 60 years old or older. So do you have any comments?
No, I share your view, Seiko. The point is that we already know very well that like cleaning the ECG is not always the endpoint that we want to prevent arrhythmias. I have the impression that there is a high variability between one patient and others, like in response to the flecainide. I think that there are very recent data published by the group of Khalife and colleagues. They demonstrated this effect is different in different mutations again, I think. And this is exactly the point. The fact is that, I mean, first we need to agree on what is like the real, let's say, concern related to Andersen Tawil syndrome, because maybe we have some referral bias, but I mean, we see patients with very severe arrhythmias and they have adverse outcomes. So in a way that I think that when we would need to have like, I don't know, let's say, they published that on 30 patients on 4 years of follow-up, and there was a reduction of arrhythmias. And I think that we really would need like larger numbers and possibly, let's say, more structured way of treating. I don't know if it is possible to envision a randomized trial, but that could be like one way to see, because otherwise, and first, this is first comment. The second is that really, I mean, we are starting to understand the different response of different mutations to the treatment. I really think that we need to face probably the fact that it is not like giving beta blockers to long QT syndrome that they respond, everyone responds. Possibly there is a variability that we need to keep into account.
Yes, and that is also our experience, that we have this family that responds very well to propranolol, but not metoprolol, by the way. But then we have another family where it's not enough, and we need to add flecainide. So I think I'm very much in agreement with what you say. Jacob, there's some questions, and I can just ask the first question in the chat. Did the other affected relatives in hindsight have clinical symptoms? And no, they didn't. They were all asymptomatic, even though they had very high PVC counts.
Very good. I would just turn back to how to start up flecainide. I think what we have done so far is doing it in the ward. So you take the patients in, and then you see the effect. And as you say, we would like to see an effect on the PVCs. And if we do not see that, that may not worry us, but sometimes, or at one time, we actually saw accentuate. And at that moment, we stopped it again, even though we don't know if it's the real outcome. But just to say, it's quite personal from each patient who will respond. There are more questions in the chat, and maybe I can read up one. We have a newly diagnosed child with KCNJ2 mutation. I assume it's a loss of function mutation. 7-month-old, leading symptoms, periodic paralysis, sometimes short syncope, ECT, QT, 400 milliseconds, no U wave. So far, no PVC documented, no arrhythmias. How would you proceed with this patient? Maybe Andrea, you will give the first.
Yes. First, I would go back to the family and see who is the other carrier of the mutation to understand, because then there is the next question by Eloisa. So let's see what is this variant, before saying. Just because a variant is rare doesn't mean it is functionally effective. And on the other side, just because it's a VUS, it doesn't mean that it is not causative, because a VUS only says that we don't know enough. So I would go back to the family first, and it's not just rhetorical. It's just. For second, on this guy, I would go for a neurological consultation just to understand what are these short syncope. Probably I would implant a loop recorder also, because periodic paralysis and syncope, they worry me a bit, but I really would like to work more with the neurologist to understand that there is not something else going on there. And if Chris, I don't know who is Chris, but if we can see the ECG of this guy, maybe next time.
Point is, periodic paralysis sometimes is well treated on potassium supplement. Sometimes also with, in our experience, we have seen with the carbon anhydrase inhibitor. I don't know if you have experienced.
Yes. Mm-hmm.
Those are also things to consider in this case, I think.
Acetazolamide, you say? Yes. Yes, we have some experience, but we didn't see much, not all patients respond in the same way. One of the aspects that you might consider is the diet, because the paralysis may be related to hypokalemia or hyperkalemia. And this is something that I was discussing. There are diet factors. I mean, I know it's soft, but diet is also important in a way. And there are periodic paralysis that are related to hypokalemia and hyperkalemia. And so the same tricks that they teach to patients with not Andersen Tawil, but other forms of periodic paralysis, like for instance, avoiding carbohydrates, big loads, avoiding long fastings, they might be effective also in these patients.
Would there be any instances where if the mother or the father is known with pathogenic or likely pathogenic long KCNJ2 mutation, would we always test the newborn? Here in Denmark, we would. Would there be any instances in your country where you would not?
I would do, just to understand.
Yes. And would you start treatment on the mutation alone? not without a phenotype.
No. I mean, this is what I think that as I appreciated about the presentation of Koichi, the fact that they demonstrated that the mutations are really connected to a phenotype and to an effect. Because, I mean, if you go and look, the mutations in KCNJ2 are not so rare. So, I mean, it means that we cannot imply that all mutations are causative. So if there are no family history, no dysmorphism, no periodic paralysis, and no ECG, I wouldn't start right away the treatment, to be honest.
But do you think, Andrea, that maybe we are underdiagnosing this? Because I mean, for many patients, it would only be PVCs, and there would be no lethal arrhythmias. So if we were thinking of all patients with just PVCs, frequent PVCs, 20%, should we consider doing a genetic testing in those patients? What do you think about that?
I think it's very wide, to be honest.
I agree. Yeah.
And this is the problem we always have, is the needle in the haystack. And in hindsight, you're right. Everybody will say, yes, I was known with these palpitations, or they saw this ECG and nobody knew what it was like, but it's difficult to pinpoint the ones that we should genetic test. So I think for now, we need to stick with the guidelines. So they need to fulfill the criteria and
Exactly.
then do the genetics.
Exactly. Yeah.
I agree.
Yeah.
Good. So one
There's a
thing
lot in the chat.
there was one question that came to my mind when I saw Dr. Cato's presentation. Quite a few remained without any treatment. Can you tell us how this was?
I'm sorry, sir. I didn't understand the question. Could you please repeat again?
In your nice figure, we saw that some of the patients never went on treatment.
Yes, I understand.
How
Yes,
was this selected?
I think so. For example, in as I presented, so many patients were diagnosed or identified by school routine treatment examination, and not all these patients were under treatment. And but because the important point of the school-based screening is that to announce all these teachers and the family members and let them understand there's some kind of a risk of these students. And some students were, for example, how to say, try to avoid this high competitive sports or training, and a special observation when they join the swimming class, for example. So this kind of this is not a treatment, this is not medication, but this is special observation for some kind of students. That is a very big important point for this school-based screening. So we doctors always think that medication is a treatment, but before the medication, there are several steps for how to say keep their daily life safer than usual. So I think some students or some parents chose this kind of special observation, and that is why not all the patients took beta blockers, not all the patients took rekinate. And I think in my inquiries, I got some impression that only for the U wave without PVCs, the clinicians did not start frekinide or beta blockers, but with many frequent PVCs, many doctors studied beta blockers first, because for these pediatricians, the beta blocker therapy is quite familiar for long QT syndrome treatment. So the people tend to choose their how to say familiar treatment for the initial treatment. Compared to the beta blocker therapy, flecainide is not super familiar for pediatricians.
Okay, thank you. Very clear answer. So this concludes our ERN webinar. I hope you enjoyed it. I want to say thank you to all the speakers, to my co-moderator, Saiko Yono, who stayed up so late.
Yeah, thank you very much for a very interesting webinar.
Thank you.
Thank you.
Thank you, Jacob. It was great to have you all here, and we are happy with all the interaction. Have a nice evening, and hope to see you next month.
Okay, see you.
Thank you.
Bye-bye.
Bye-bye. Bye-bye.